So good afternoon. Welcome to the 2015 Innovative Applications in Analytic Awards second session. So we've had a finalist from American Airlines speak earlier today. And at this point, we have the team from Mayo Clinic sharing their work on the intelligent surgical scheduling. So from Mayo, we have Dr. Nargis Hussaini, Kalyan Pasupathy, and Jean Huddleston. Just a couple of housekeeping items. All the contesting teams get 35 minutes to present. We reserve 15 minutes for question answers, and the chance is to ask those questions for the first is reserved for the judges that are sitting right here. If we have any time permitting within the 50 minutes, we'll open it up to the audience. Certainly the team has agreed at the end of the session, if any one of you has questions, they would be happy to answer them after the session is over. Also, this session's being recorded, so please minimize the walk around so it kind of helps out with the recording. And with that, I'll turn it over to you. Thank you.
Thank you very much. Dr. Kal Pasupathy and Dr. Nargis Hussaini, both PhDs in industrial engineering. Myself, I'm a practicing hospital physician at Mayo Clinic, and about midlife crisis, went back to school and got an IE degree. And it was through that classwork that we came up with the intelligent surgical scheduling system, and Dr. Esma Gell, who was on my thesis committee, is here as well, so thank you. Mayo Clinic. Been around for 150 years, starting in the cornfields in Minnesota. We see over 1 million patients a year in Rochester, Minnesota, with over 100,000 admissions, more than 600,000 hospital patient days, and more than 60,000 employees. Revenue is about $9 billion, with an income of $612 million and benefactors of about 400 million gifts per year. This is where our study took place and where our applied work has taken place. This is St. Mary's Hospital. It has over 1,200 beds and nearly 100 operating rooms. The group that we were working with was spine surgeons. During the time preceding the onset of the work, we followed patients from the outpatient setting all the way into the operating room. We followed the surgeons to mix and understand the difference between the patient flow and the surgeon's workflow in order to figure out, as we were developing a solution to optimize the operating room time, how can we actually meet the patient's needs while we're meeting the surgeon's needs and the institution's needs. Our spine surgeons that we worked with are both neurosurgeons and orthopedic surgeons. There's 12 of them in total, each operating every other day with the outpatient clinic on the opposite day. The problem that we identified as we were doing our initial scoping and analysis of the actual practice and determining what current state was, is that there was a tremendous amount of surgeon variation in their operating room utilization. They often had also some empty days. So does anybody have back pain? Back surgery? Anybody have back problems before? The surgeries can be really long. Some of them are only about 2.5 hours long, but many get up to 8 hours and 10 hours, and the longest one that I know of was nearly 24 hours in duration. That person had surgery from the bottom of their head to the bottom of their sacrum. So the duration of those can be so long and so short that actually figuring out how many can go in a day is not an easy problem, especially if insurance decides to cancel the surgery the night before, and that surgery happened to be a 12-hour case. Now you've got nothing. You've got staff showing up, and you have no procedure to do. So it introduces some interesting challenges in a scheduling perspective. So we had fluctuating days of low and high utilization, with some surgeries going way past 11 o'clock p.m. And from our surgeon's perspective, when you've been operating for more than, 16 consecutive hours, you get a little bit fatigued. You're probably not as hydrated anymore. Your nutrition has been bad. Your hands shake a little bit more. You do not want to be the surgeon on the tail end of that day, or the patient for that matter. So we wanted to be able to, while optimizing the operating room utilization, not over-optimize, not go into overtime. So overtime is bad. Undertime is bad. We wanted to find a nice balance so that our patients could have good outcomes in a very safe setting. The other thing that we did that was a little bit unique to an OR optimization problem was we actually took into consideration the length of stay after the surgery. So if you're a Medicare age patient or an older patient in Minnesota, and you need some skilled nursing care before returning to independent living, there's a moratorium on the number of nursing home beds in the state of Minnesota. So if they're all full, you stay in the hospital. And hospitals or nursing homes won't take patients on weekends, on Saturdays or Sundays, because their staffing is lower on the weekends. So if you have an elderly person you're doing a big surgery on, they need nursing home placement, why would you do their 3-day length of stay surgery on Wednesday when you know they're going to get to stay in the hospital at Hotel St. Mary's on Saturday and Sunday? You would actually do the surgery on Friday so that they can heal during the weekend and leave and go to the nursing home at an opportune time. Every day you're in the hospital increases your risks of adverse events, falls, infections, medication errors. It's not a great place to be when you don't have to be there. And so we really wanted to take that component into our consideration as well. So as we looked at this problem, needing to optimize the operating room utilization, improve the safety of our patients, use our surgeons, the most expensive resource we have, well, we had multiple perspectives that we needed to consider. So the first is the patient, the person in pain. They want surgery as soon as possible. If surgery is indicated, they want their pain to go away. So we don't want long waits. So we need to balance the load as much as possible across our surgeons. And they don't want an unsafe case. And they don't want to stay longer than they have to. We actually ran all this by our patients. We have something called a Patient and Family Advisory Council, and we brought patients and family members together and asked them about what their needs were when they have bad back pain and around the time of surgery. What do they want to know? How do they want to know it? And it was their input that actually went into a lot of the user interface that you'll see in the application that we developed. From the surgeon's perspective, they want to know when their day is going to be over. They want to be able to tell their family if they're going to make it to the soccer game that night. Some very practical work-life balance things. And they want to know if they're going to be there late so they can plan accordingly. And then our institution. Empty days in the operating room are a bad thing. Too much overtime is a bad thing. Adverse events in the operating room, a bad thing. So we need to minimize those as much as possible and improve our overall operational performance in our operating rooms. So we took all of those things into consideration as we were developing it. So we had some very practical requirements, or clinical requirements, I'll call them. We needed to promote patient engagement. We needed a scheduling system that was clinically relevant. I don't know how many of you have worked with surgeons or doctors, but we don't believe administrative data. In fact, we hate administrative data, billing data. We don't want to use it. So we wanted to come up with an alternative way that would be more clinically relevant, that would help with the uptake in our surgeons and help them accept the tool. It had to pass the clinical relevant sniff test. And so that was a big challenge that we had. We needed to make sure we optimized prime-time OR utilization, eliminated days with no surgery, avoided our weekends, the unnecessary days, and reserved enough capacity for those really long surgeries. So we took a 3-tiered approach to doing this work. We had our descriptive work, where we did some data mining and a lot of interaction with the practice. Every step that we did, as we were identifying the clinically relevant variables for our surgeons, were bounced off the surgeons back and forth. We met with them on a weekly basis as we were developing our model. Then we did predictive analytics to determine what we were going to actually do in terms of describing the durations of the surgery. Dr. Husseini will go into that in more detail in terms of the different prediction models we put together. And ultimately, the prescriptive analytics, where based on all of the parameters that I've mentioned, our system will actually select the best days that meet the patient's, the institution's, and the surgeon's needs and make it easy for the patient and the surgeon together to select the day that best works for them. Finally, we actually did an implementation. The data that we'll show you is from our real implementation. And I'm now going to turn it over to Dr. Husseini to describe more about the actual work.
Thank you. So as you could see, there are a lot of different components that went to this model. So I tried to go over all these components briefly, and we will answer questions at the end if there are any. So one of the things that we wanted to figure out was to predict the duration of surgery. The duration of surgery is one of the most important components in any scheduling problem. So currently, the state of the practice was to use moving average of historical moving average of overtimes, and the system was allowing the scheduler to modify this time. This is also the method that is used in most of the commercial softwares. There are several different researches that has been done in predicting the duration of surgery. The most closest one to our work is using the ICD-9 codes to predict the duration of surgery. This approach actually is not very practical because the ICD-9 codes are basically the codes that are used for financial purposes, and also they are not known at the time of the scheduling, but after the surgery is done. So for that, we came up with our new method. The OR times that we're trying to predict consist of 3 different times. The previous work that has been done in the literature look at these predictions as one piece, basically the one piece, which is the OR time. But we are breaking these times to 3 pieces, and that is from the time that patient comes to the OR until the time that the patient is cut for the surgery, and then the time which is the duration of surgery, and then when they close the patient until they take out the patient from the operating room. We noticed that this 3 piece represent the predictions better, because there are different factors that affect each of these times. So, for example, if I want to give you an example, the patients are positioned in the bed in the operating room, and that is dependent on the type of surgery that they're going to have. So there are, for certain type of surgery, they put the patient on the prone position. In some other type of surgeries, they put the patient on supine position. So the preparation for each of these are different. This preparation impacts the first portion of the OR time, but not the surgery time. So for that, we broke these times to 3 pieces. And also the number of levels of surgery and the location that in the spine that, we realized that the duration is dependent on the location of the segment that they want to do the surgery on. We noticed that there are a lot of different factors that we have to consider. There are some of those factors that are general factors, such as age, gender, and these factors are existed in the system as a variable field. But these factors alone cannot represent the duration of a spine surgery, which is very variable, as it was mentioned. So it's more about what is done during the surgery. So then we had to go further and find different factors that really represent the duration of surgery. One of the challenges was that most of the data that is available is unstructured data. Pre- and post-operative notes are free text notes that the surgeons write before and after surgery. So we had to do data mining and text mining to figure out the variables that we really need to take into consideration, and coming up with many different factors, and then take those down to the number of factors that we could accept. So we use those factors to predict the duration of surgery and length of stay of patients. We used 4 different methods, data mining methods and machine learning, the supervised and unsupervised machine learning, to predict each of these durations. And for each of those, we picked the best method that was applied to that prediction. One of the goals was to come up with the probability of end of the day. So the surgeons wanted to know that with what probability their day is going to end at a certain time. because we didn't want to have a lot of overtime and undertime. So we wanted to know what is the probability of going overtime or having undertime. So considering that this problem was not a straightforward problem and we have to come up with a numerical method to calculate these probabilities, we had, just imagine that you have two surgeries that next to each other, and then you want to find out the probability that combination of these two surgeries is going to pass 5 p.m. So one of the things that we have done, because we couldn't work with one distribution since the distribution of surgery was very wide, so we tried to classify this duration of surgeries, classify the type of patients to the groups, and use classification to categorize these surgeries. And so having a distribution, have a better, more accurate distribution for each of these categories, instead of using one distribution for all. And then, so we knew that finding the probability of overtime, we have to have the density function. And then we used because we had to do the convolution, because we had the sum of the durations and we had to do the convolution, then we had to find a numerical method for calculating the density function. So we used fast Fourier transform and its good properties to calculate the probability of overtime and undertime. And we use these probabilities not only to inform surgeons at the end about the probability of overtime and undertime, but we also use those in our scheduling algorithms and took that into account. So after calculating all these components, we had to come up with a scheduling algorithm to basically figure out what are the days that we want to show surgeons and patients for their surgery. We considered the overtime and undertime and their probabilities into account as one of the components. And we also, what we had in mind was not to show only one solution for as output to patient and surgeon, but multiple solutions to make it practical. So in the literature, there are optimization-based problems for surgical scheduling, but these approaches usually are not very practical because, for first reason is that when you have an optimization problem, a scheduling optimization problem, you have to have all the surgeries as a batch and then try to schedule them at once. So this approach is not very practical because the patients arrive one at a time and you want to schedule them one by one. So the way that this problem is handled in the literature is basically they use the historical data and they create the distribution or arrival of patient based on that, and they write the optimization model. They solve this optimization model for several instances, and then they create a template based on that. For example, saying that if the patient has condition A and B, then I schedule that patient in a Monday. Or if the patient has condition C, I schedule them on a Tuesday. So when it comes to the template base, we cannot really say that this template is optimal because it came out of optimality. It's the result of analysis of this optimal solution, this many instances. So it's not optimal anymore. And also, it gives us only one solution at a time. So that solution might be accepted by the surgeon or doctor, and a lot of time it might be rejected. So in order to get over that problem, because we wanted to have several solutions, we divided our horizon to 4 sub-horizons. The big horizon was 90 days, and we divided that to 4 horizons. And we wanted to guarantee a solution, if possible at all, in each of these horizons, and maybe more than one solution in each of these horizons. And then we wrote an algorithm based on reward and penalty that basically ranked the days based on the reward and penalty that we assign. So, for example, we're giving reward for discharging not discharging on weekend for patients that are going to nursing home. We're giving reward for filling up the closed dates, but we are penalizing for having undertime, overtime, and filling up empty days if they based on the time that they have from today. So based on that, we give weight to each of these components, and we rank the reward minus penalty. But as you realize, I said that we give weight to each of these components. So those weights should be figured out because that's very relative. Therefore, we had to make a simulation optimization to come up with those the value of those weights based on the goal of our system, which was certain utilization and certain constraint to be met. And now I pass it to Dr. Pasapati to continue.
Thank you, Nargis. So we've been just hearing about the surgical scheduling problem and taking us a step back. As the patients come to see the surgeons and it's determined that the patient needs surgery, we are going through the process of trying to figure out the duration of the surgery and to schedule the actual procedure. And we have done all our discovery process with descriptive, predictive, and prescriptive modeling and analytics work. And now we need to put it in the hands of the surgeons. So that's where we worked with our IT team to develop what I'm showing here is a screenshot of the decision support that we developed, which actually, based on the factors that were determined by the descriptive analytics component, lists those factors, ranging from the number of levels in the procedure, which levels, cervical through thoracic, lumbar, sacral, so on, whether the patient needs a fusion or a discectomy. And those are all factors that surgeons can relate to. Traditionally, the way it was done was purely based on ICD-9 codes. So now this passes the clinical sniff test. When this is shared with the surgeons, they look at it and they're filling it out. Oh, this makes sense to me. This kind of procedure, these are the so many levels, and that feeds into the prediction that we actually share as durations for the three phases that we talked about: the time to incision, skin to skin time, which is the actual procedure, the surgical procedure time, and closure to exit. In addition to that, the length of stay for our nursing home patients. All of those predictions come out of those based on these factors. Now, so as we were working on this, one of the things that came up was with regards to the height and weight. Now, how do we pull that information? So that was actually pulled from existing systems. Again, working with IT and our surgical scheduling team, we pulled that from the electronic medical records to populate that and give the option to the surgeons or the scheduler to be able to make that change before it gets scheduled. So once the duration is predicted, we get to our scheduling decision tool. And actually, these two tools work together. So the duration comes out of it and then directly brings the surgeon or the scheduler to the scheduling tool, where as a surgeon, in this case, I happen to be Dr. Clark, and I'm trying to schedule a procedure for the patient that's in front of me, and it shows my calendar for the next several days. It pulls up my calendar as the sequence of days that I have available, and I'm based on the duration. On the far left, right below Dr. Clark, you see a little bar right there. That's actually the procedure that already exists on that given day. And actually it also shows the duration as well as a probability estimate, and that's the likelihood of what is the likelihood that procedure will be done in that time frame. Now, there is an additional procedure that I'm trying to schedule. So if I put it in that slot for that day, now it's going to say, well, can you be done by 5 o'clock? You have, let's say, whatever the duration comes out of the prediction component, it might say, well, you'll get done with both procedures on that particular day by 6 o'clock with a 30% likelihood. Now, probability and likelihood is something that physicians, clinicians can very much relate to, and they love that component of being able to see that, and they can make a judgment call. This particular procedure, 30% likelihood, which is not too high. So at 6 o'clock, it's okay. So we can move ahead. We can go with that, scheduling that procedure on that day. And that's where we get to the, being able to determine that sweet spot. what's from a scheduling standpoint, what's a sweet spot. We're also able to pull up other surgeons' schedules just for a subset of our procedures that we call as efficient cases. These are all very, spine surgery cases range quite a bit, but then there are a few procedures that are actually very well defined. It takes a couple of hours. There is no resident or learner in the room, so it does not vary much. So surgeons know for sure that they can get it done in a couple of hours. So just for those procedures, there is understanding between the surgeons that they can also schedule it on another surgeon's calendar. That's why I'm showing a second surgeon underneath there. So going through the implementation process, this has been a great learning process for all of us in the team. I was talking about the data extraction load. So we had to extract historical data that actually exists in the system, because we're really talking about a current process that they already have in place, where patients call the scheduler, they schedule the procedure, and life goes on. But now we're coming with this new tool, this analytical model, which is embedded in this decision support system. And for this to be successful, this needs to be embedded in their workflow. So we had to take the historical data that exists. This includes clinical data. This includes current procedures that's scheduled on their calendars, so that our system can compute those the convolution and the combined probabilities of getting done by 6 o'clock, for example. So we needed to extract and reload all of that data into our system. Dual entry. So as part of the process, again, as we're doing this, there was a point in time where we had to work with the clinicians to get them to work with two systems, because they had their current system and we were still, pilot testing, prototyping. So we had to get them to enter data in two systems. So we got a team of surgeons that are actually helpful to work with us in doing that. We're talking about spine procedures, spine surgeries. These are performed by both orthopedic surgeons as well as neurosurgeons. Now, neurosurgeons also do brain surgeries, which was not part of our initial descriptive predictive analytics work. But these procedures exist on the neurosurgeon's calendar. What do you do about it? How can we calculate those probabilities now? So that was a problem that we faced, again, going through implementation. So our solution for that was we ended up taking the actual duration of those brain surgeries. Assume that it's already scheduled. We just take the actual duration. And of course, that is an assumption, but brain surgery not being part of our analytic process, we cannot estimate probabilities for those. So for now, the time being, we actually use this actual duration as it exists. Moving forward, when we work with brain surgeons, for example, we'll be able to, again, do a similar process of determining probabilities and distributions for that. And also, the workflow and acceptance and trust is actually a major component of it, where we spent several hours working with our surgeons, schedulers, and practitioners, where we would take some of our results. We'll take a sort of a snippet of the actual procedure, describing it by those factors, a 4-level cervical to thoracic, discectomy, cancer patient, that might end up going to a nursing home, give all those factors and get them to predict what the duration they thought it would be. And we would, in the same meeting, run our model to predict what our estimate was, and then share also the actual duration from the historical data. So, those kinds of sessions were actually very crucial in actually for buy-in and being able to sell our tool and see the value of what we are trying to accomplish here. So this went into implementation, and I'm sharing some of those results in terms of what kind of a difference we made in terms of prime time utilization, which is the way it's defined is actually a 10-hour period during the day, and it ends at 5 o'clock in the evening. So again, historically, each surgeon, when they get an operating room assigned, they are responsible being able to schedule surgeries for that operating room. So prime time utilization is a metric that's actually measured by the institution. So using our tool, we're able to put those pieces of those puzzle in the right way so that we're able to more effectively use that prime time utilization and increase it from 44 to 66%. Days with no surgery, which we internally call as no hearers. Again, that's something that we actually reduced drastically to almost more than half, from 33% to 16%. Finally, days with overtime, which is again, unsafe. What we call as an unsafe, beyond a certain extent, as an unsafe day, both for the patients as well as the providers. So here we sort of have a video showing our tool and play in a surgeon's clinic with a surgeon working with a simulated patient. Obviously, we cannot show you a real patient.
I will use this calculator to try to determine the most optimal days for you, which are highlighted in green. You can see these are the March dates. Could you select a date or think about which date would be best for you?
Okay, how about we look at the 19th?
Our partners that are on the other green days, Dr. Marsh is one of our senior spine surgeons also, and he would be best.
So I introduce to you Dr. Paul Huddleston, the surgeon who led this initiative from the clinical perspective and is unable to be with us here today because he's actually operating. But the ultimate impact to this particular practice was that we were able to increase flexibility for the surgeons and the patients. I don't know how many of you have ever sat with somebody before who was scheduling a surgery and you've just been told you're going to have a big surgery on your back or your chest or somewhere. People retain less than 30% of what they're told at that point in time. Now they have to pick a date. It's very difficult cognitively for patients and their family members to work through that. And so providing them a visual tool so they can pick a green day that works best for them really improves the patient empowerment component of this. Not to mention, we were able to work harder, not smarter. So there were a group of surgeons who didn't use this when we did it. We started just after our CEO gave us a big talk about what the new ACO laws were going to do. So the sky was falling. Everyone had to work harder. Everyone had increased utilization when we were doing this. However, the ones who used the tool had decreased overtime and had a higher NOI. The ones who did not use the tool had higher OR utilization, but had higher overtime and lost money. So one group worked harder and another group worked smarter. And the visualization, surgeons are visual, the visualization was very helpful to them. So we reduced the overtime, we informed decision making. Surgeons want to know what they're doing. They have it in their heads. They think they're the best schedulers ever. But as the other Dr. Huddleston will tell you, if you play chess on the computer games, even every once in a while you can beat the electronic chess player, but not all the time. And very often once you crank up the difficulty enough, i.e. fatigue, workload, personal issues going on, you can't beat the computer as often. And so this allows us to have more consistent scheduling and more consistent utilization of our operating rooms. And then lastly, scholarship. We work in the Center for the Science of Healthcare Delivery at Mayo Clinic, and our mission is twofold: to improve the practice and also to inform the science. And so both of these missions are being met. We'd like to acknowledge the Kern Center who has supported this work for us, our Department of Orthopedic Surgery and Neurosurgery who embraced this as an opportunity, and our IT programming team, as well as the award committee. Thank you very much.